Hey Mo,
Hey, Ricky, how you doing?
I am great. I'm so excited about today. The doctor is in,
Yes.
and I'm now on this screen with two like phenomenal badass doctors, and I'm so happy to be here. And we have like in the incredible, the wonderful, the phenomenal Dr. Gigi.
Yeah. I'm like
Thank you.
fangirling out over here.
I
Dr.
know,
Oh,
Gigi,
girl crush all
welcome.
around. We've
well,
been waiting
thank
to
you.
have you on our show, Dr.
Oh,
Gigi, and we are so happy to have you. So happy to have you here.
can I tell you, it can be hard out there in this mainstream world. And so to be in your hug and to be embraced and
You
to
got it.
be shown all this love, thank you. That just warms my heart. Thank you so much.
You have to feel our hug because it's so here. And so, we're so glad you're here to talk about it. So we just want you to tell your story. You're a two-time cancer survivor from two kinds of cancers. The breasty thing is like I think maybe your easier cancer. God bless you, right? And then, we've been on this when we trial bandwagon, trying to get more women into clinical trials, and you have such great experience in that space. So let's just talk. Let's just talk.
Okay. All right. So let me tell you a bit about myself. I'm 62, and I think I chose my parents pretty well. Those Egyptian genes and a little melanin helps. So when I was 45, I was in a very bad marriage, and thank God the ex, he left. But shortly after he left, I felt a lump in my breast. And so when I went to get my mammogram, I realized that I hadn't gotten it for several years, because when you're in a not good situation, right, you've got competing priorities, right?
Right.
So I've made it a point, actually, when somebody's going through a hard time, say, have you, done your screenings, your breast cancer screening, et cetera. And so I went, and sure enough, there were two tumors in my right breast, not one, but two. And, because I was a doctor, because I was 45, I wanted to give myself the very best chance. So I had a bilateral mastectomy, and it turns out that there was a tumor in my left side. So I was just very glad about the decision that I made.
Wow.
I was lucky in that I was ER/PR positive, but I was also HER2 positive. So at that time, we would do the surgery first, and then I got my chemo. And this is really where my weight blew up, because it tipped me over into menopause, and I had to take, a lot of steroids. So I gained probably 35, 40 pounds. I lost all my hair, and I found that I have a pretty shaped head.
Yes, you do.
I did not know that. You find things out, right? And so my dad especially, he would take pictures of me and, with the flowers and everything. And there is a beautiful statue, if you've never seen it, it's made out of wood, of King Tut, and it's coming out of a lotus. It's about this big, it's not very big. And that's what you look like, he said. So I felt very embraced and loved and supported. And then, of course, after the surgery, I had my chemo. And then, of course, I went through the divorce. So when people would say, oh, I'm so sorry that you have cancer, I said, you know what? I've got this. Because the thing that for me was much more life-threatening and soul-crushing was actually the marriage, because it was a violent marriage. I was not struck, but there was a lot of violence. And he was another doctor, by the way. But at any rate, so imagine this, he was his own attorney. So I've got one more chemo. It was July. I'm in my wig on the witness stand, and he is cross-examining me.
Oh my God, but he's a doctor, but he acted like a lawyer.
How was that even, how was that even possible? It seems like operating in your own self-interest. Well, I
Well,
guess, but
whatever.
yeah, whatever.
Cross-examining you, like, that's crazy.
Yeah.
Wow.
So the
Talk
good
about
thing is,
fortitude, though.
I know, right? I had a great judge, and the judge was rolling his eyes. That's how bad it was.
Exactly, right.
Anyway, so this whole time I worked full time, and I, because it was helpful for me, given everything that I was going through, to be distracted. I'll tell you about the second cancer go around. And I think it's also, I was young too. And then after the first year, I decided that I was going to have reconstructive surgery. So I used my own self
Right.
And the first surgery was 23 hours, girls.
Oh my gosh.
And I took myself off the respirator. Listen to this. And I said to them, are we done already? And they all started laughing. This is in the operating room. They said, we've been here for a full day. Anyway.
Weren't you knocked out? Why weren't you, you weren't knocked out?
No, I was,
Oh,
but
and
I had
you woke up.
extubated myself
Okay,
in
okay.
the operating room.
Oh my
And
God.
then she had to take me back for another 7.5 hours. So I was in the ICU for 8 days.
Oh my
I
God, what
have-
happened? What happened?
Well, because of the reconstruction, it turns out that I had very big arteries, but my veins are very small. And I took that as a metaphor, like a lot of women. We give a lot, but we don't know how to receive, right?
Oh my goodness.
Oh,
Ooh,
wow.
So that's
Wow.
really been my life lesson, because I am one of those people, I try to find meaning in bad
Yeah.
things. So it really
Wow.
made me just a lot more gracious, because I realized that when you're giving, and not allowing people to give to you, that's actually a form of selfishness if you think about it. Because it's saying that only I can give and only I can have the pleasure of giving, because it is very nice to be able to give. So anyway, so I had 8 days in the ICU, 8 units of blood. And because the flap wasn't doing well, I reintroduced leeches. I had to have leeches for 2.5 days. Yes, ma'am.
Oh my gosh.
But it saved the breast. So anyway, that was the first go round. And I was very lucky. I was on the Arimidex for 5 years. And
What stage was your cancer, of your breast cancer?
well, because it was so large, there were 2 tumors, actually 4 and 5 centimeters.
Wow.
But there were no lymph nodes. I was really lucky just because of the size. It was a stage, this is going to sound funny to you, but actually I'm going to quote you some research studies. I never went into my chart and I never read about anything. And that's actually been shown to have a better outcome. And let me tell you why. As long as you do what you're supposed to do, this kind of benign neglect of, how people say, I'm not claiming it, right?
Right.
So that if I do what I'm supposed to do, right?
Right.
You have to do everything. And I didn't read or whatever. So it was at least a stage 2. It was a large tumor. So fast forward, and now 17 years later, it's COVID. I'm working in the hospital taking care of COVID patients. This is, And then in July of 2020, I noticed I'm bleeding blood clots of urine in my urine.
Oh my God.
But you see, what I want to say, and this is so important, because you both work in a space where you want to get the very best care for everybody.
Right.
And because of my privilege, as given my education and the fact that I was a physician, between the time I had the symptoms and me starting chemotherapy was 2 weeks, because I was able to navigate, right?
Make it happen.
So
Wow.
this time around, because the cancer paradigm has shifted, we did the chemo first, and then they removed my kidney, because studies show that's better. So, we talked about clinical trials. So my doctor said, there's a clinical trial at the NIH looking at whether there would be benefit from getting a monoclonal antibody. I said, okay, well, let me go. And so I actually, got to work, and I'm still under her care. The best person in the world. She is the authority. And she said, the results of this monoclonal antibody, we're not even sure if it really works, because other ones that are like it have not really been that great, but it's a fairly, not benign, but it's okay to, take it. So I was randomized into the observation only trial. And by the way, I could have dropped out at any time. After I got randomized, I could say, see you, bye-bye. But I knew that with her, if anything changes and there's evidence that this treatment works, then I could go immediately to the treatment. So
can you explain what the antibody is to our audience?
Sure, monoclonal. So there's been a lot more, as you can see. There was just a story that broke yesterday about how activating your body's immune cells to attack the cancer cells, which if you think about it, instead of attacking all of the cells like chemotherapy does, so that's why we lose our hair and, you know, all these other things, it's just basically going after the cancer cells. So it's a lot less toxic, and it's your own body that's fighting it, right? So, so there was just some very exciting trials. We'll see how applicable that is, that show that this has been successful. There's one particular type of antibody, monoclonal antibody, has been successful. We'll see, you know, but the study that was just released was about rectal cancer, which can be really difficult to treat. And so breast cancer, especially in women of African descent, specifically of the African diaspora, because we know that the African diaspora causes a lot of genetic changes which are different from those of us that come directly from the African, you know, motherland, right? So the reason that this is so important for us to learn about is that women, Black women, are more likely to have the triple negative breast cancer. So what does that?
That's what I had.
Yeah. So you can speak to that, but basically, just to review, you don't have the estrogen or progesterone, and that's really the target for chemotherapy.
Right.
So chemotherapy is not as effective, right? And if you're HER negative, which is another protein, then the medication I got, Herceptin, is not something that you could get.
That'll work, right?
And so why these clinical trials are just so important is because we need to find something that works. It can't, you know, these things can't work for some people. And especially if the majority of them are white, and then you're leaving out a whole group of Black women, and, you know, survival is not as good. And, you know, it hits you younger, right? So the potential of life lost is much higher for Black women. We've all heard stories of young Black women having cancer, triple negative, in their 30s, right? And so the whole thing about trials, a couple of things that I wanted to mention. Because I'm in Washington, D.C., the trial that I'm part of is at the NIH. I joke with them, I say, I'm coming for my spa day. I swear to you, I look forward to going. And let me tell you why.
Spa day.
First of all, they do all your blood tests, they do your scan, and you get the results and you talk to the physician all on the same day.
That's phenomenal.
And you don't get any bills.
Mm-hmm.
And everybody is really so nice there. And they call, you know, they call you and check on you. How are you doing? Do you need anything? You know, I can always call somebody on their cell. I don't have to wait in line. And by the way, I'm not getting any money for saying this. I don't get any money from anybody. So I don't have a vested interest other than wanting to advance science so that people can live their healthiest and best lives and don't have to go through what we went through, right?
Right. That's amazing. So how did you get into that trial? Like, your doctor recommended you, right?
My doctor.
Our problem, you know?
Yes.
You have a great doctor and you are a doctor.
Yes.
So our ladies, our women are not getting asked to participate. And, you know, most of them don't even know what it is. So
right.
They don't even know to ask, you know, that's what we're trying to teach them.
Yes. So one of the things, you know, of course, you know how it is when you go through something, you're more likely to teach others. So I had always told people about clinical trials, but now I'm really telling them, so they can go to clinicaltrials.gov. You can just put whatever kind of cancer. You can say how many miles you want to be away from where you live, or if you want to look at all clinical trials. They're all worldwide, by the way. So I've actually had people who are in other countries who, you know, wanted to get great treatment and then have them get into a clinical trial abroad. And what's so powerful about this are there's so many different ones. The one that I was in was treatment, a new treatment versus observation. But there are trials that look at genetics, that look at quality of life, that look at diet, that look at exercise. I have a patient right now, she's got lupus, and the trial that she is in is just to see if exercise makes a difference for her. And so she's in a structured program. And guess what? It really helps her lupus.
You know, I think
Wow.
that's a huge misconception because as soon as people hear that word, the two words, clinical and trials, they think drugs and they think experimental drugs. And we've really been trying to change the face of that because sometimes a trial is using an existing drug that we know works for other things, like a Keytruda, for example. Ricky, I know one of our favorites for TNBC, right? For lung
Right.
cancer, started in lung. And then we said,
Right.
well, can we use this for
Right.
breast, right? And
Right.
so the drug has
Right.
already been proven to
Right.
have some efficacy. And I think when, we have to really talk about what people understand and improve the level of health literacy in the community, because there's so many more myths out there and misconceptions about what a clinical trial is. So I'm sharing your pearls in the chat, Dr. Gigi, because people need to know that a clinical trial means more personalized attention. It's your
Yep.
spa day in the sense that you are the most important person there.
Yes,
Yeah.
indeed.
I've
And
actually done 3 this year already. And there's a program, Georgetown and Howard have this program. And I did one for Black fitness, like my fitness routine for Black survivors versus white survivors. I did one for chemicals in your body, and I wore these 2 bracelets for a month where one was measuring the stuff in my environment and one was measuring the stuff I put on my body. And then I just did one a couple of weeks ago where it was a 1-day trial, go and do blood work, and they basically are testing DNA versus white versus Black breast cancer and breast cancer survivors. And so, I keep trying to walk the walk, Dr. Gigi. And so if I can do a trial, I'm going to sign up to do it because anything we can learn is great. And, one of the biggest pet peeves I have about breast cancer is that whole thing about lumpectomy and radiation is equivalent to a mastectomy. And so not for Black women. And so I looked up the study that was done with. That study was done in Sweden.
Yes, oh, yes.
You know what I'm talking about? I'm like, so how many Black women were in that trial? None.
Well,
And so-
let me just piggyback off that, because one of the studies that they had said you don't need to have a mammogram every year during your 40s came out of a study which they were looking at 6 different sites. And it was not ethnically diverse. And they
Right.
didn't even have, sometimes the radiologist would read bone x-rays in the morning and mammograms in the afternoon.
Mm-hmm.
So what I've always told women is that you want to pick like 40, unless you have a family history, you got to do it earlier. And you do a mammogram every year. Why? Because when you're younger, your breast is like a gland. Mammograms are
Right.
not that great in younger women. And so you have to follow it from year to year to pick up changes. Mammograms are easier to identify breast cancer when you go through menopause, because guess what? The breast gets replaced with fat. So it's the younger women, and now they're using more ultrasound, but that's another area. We need to figure out a way of looking at dense breasts. So
Right.
what happened, just like in men with prostate cancer, by the way, they changed the guidelines and they said, oh, you don't have to worry, the prostate cancer test is not that good. Well, first of all, we begin screening African-American men at age 40. And yeah, it's not a perfect test, neither is a mammogram, but guess what started happening among Black men? The prostate cancer rates started to go up. So, this one size fits all doesn't work. And even, look, we're, just because we have melanin in our skin doesn't mean that we're all the same either.
Right. That's
Right.
Right.
And so that's another thing that we can learn. But I have to tell you that the whole issue of clinical trials came up. We're part of the Rodham Institute is part of the Black Coalition Against COVID. And lots of people were initially very skeptical about the vaccines. And what we did, and it's a national organization, we had all the, historically Black medical schools and faith-based fraternities and sororities, the whole group. And we actually worked with the descendants of the Tuskegee.
Tuskegee, yep.
Love that, yes.
And it's called The Legacy, and people can go on there. And they actually were talking about clinical trials and how the sacrifices that their, you know, men in the family, whether great grandfather, grandfather, uncle, or father, actually, because they were not given the treatment, a
Right.
lot of the things that happened to assure safety was basically as a result of the travesty that happened.
Right. Right.
So, and you know, look at us on this show, right? Having more diversity, more voices matters. And
Right.
that's why I
Representation
really
matters.
push to have, you know, physicians, nurses, physical therapists, radiation, you know, technologists, all of that from as many diverse backgrounds as possible, but specifically here African American, because studies show when you have people of color taking care of other people of color, guess what happens? Everything gets better.
I think it's better. And you know, we learned too we did a research study last year, and you know, the voice of a breastie is really powerful. And when I hear other breasties giving bad information, like you're going to get the sugar pill and die, I have to correct them. And so a lot of the work we've done with whenwetrial.org is to educate our breasties so that because we turn to each other. You know, I went to the doctor, they said this, but Ricky, what do you think? Or, you know, breastie, what do you think? And so I want to make sure that we are armed with the right information. And also we can make it more digestible for people.
Absolutely.
They need to hear it in elementary, easy to understand terms. And when they get it from the right voice with just the right level of understanding, they get it and they change their minds and they act differently. So we're trying to
The studies show that too, though, Ricky, you know, that when we physicians spend a little bit more time with patients and take our hands off the doorknob and sit down face to face and talk with the patient, women are 23% more likely to consider more aggressive things like chemotherapy because they understand a little bit better what's going on. It's not just, you know, my nurse is going to talk about this trial, I'll see you later, or you go see that doctor over there. You know, even as a surgeon, we have to introduce that. And what you're speaking about is like health literacy doesn't begin just because you have a diagnosis. And we see so many women who go through their entire treatment journey never understanding even what type of breast cancer they had or that there are different types.
Right. And they don't talk about it. You know, we have like, you know, we really need to make health a topic at the kitchen table for Black families because we are not talking about it. And you know, we have these young women that they don't know their HER. I said, know your HER story, feel your breasts. What do they feel like? What do they look like? Stand in front of the mirror, get to know these babies, you know, and your whole body, because you know better than anyone else. So you won't get dismissed when you go to a white doctor and they tell you, oh, that lump is nothing, come back in 6 months. You can say, hold on, wait a minute. I didn't have this a month ago. It's not part of me, you know, take another look.
Or here's something else that I don't think we do enough of. Go to another doctor. You know, think about it. When I go to get my hair done, my hairdresser just moved like 2 hours away. So I've been trying to find a hairdresser and went to a couple of them and it's like, no, I don't like it. And so I've got to find somebody else. I mean, think about it. If we had that same attitude towards our health, you know, a hairdresser is important, of course, but a physician or a clinician is more important, not to cut on hairdressers because, but you know what I'm saying is that we have to be as picky there and to say, you know what? No, I didn't get my questions answered. I want a second opinion. This doesn't make sense. You're dismissive. I want to understand more. So I completely agree with you.
Yeah, you know, we're also seeing a lot of doctors that don't understand triple negative. And I get so many calls from new breasties who have TNBC. Their doctor has no clue about Keytruda or Trodelvy or any of the latest therapies. And they're calling to ask questions. And you know, then I'm gonna get a second opinion. And actually, you know, Mo, yesterday I was on a call on this committee with Dr. Ruth O'Regan. And she was my second opinion who put me on the drugs that saved my life. And I haven't seen her in 10 years.
Wow, look at that. Look at you now.
I know, right? I was so happy to see her. But it was because I went to a second opinion because my doctor said I can't do anything for you.
Incredible.
And so but I had to stand up and wait a minute. I don't feel like dying right now. You know, what are we going to do? And I went to her And she was, one of the few doctors at the time kind of studying triple negative. And she put me on carboplatin and gemcitabine, which were experimental for TNBC right then. So it wasn't a clinical trial, but still it were drugs that we weren't standard of care yet. And I, had I not done that, I'd be dead.
Well, and it just goes to show you that because she was knowledgeable,
Right.
you, Ms. Ricky Farley, has helped to advance the treatment for other women that would have not done well because you have advanced the knowledge. So you are helping, you're impacting women that you've never even met before.
Yeah.
Just by what you did and how you were treated, not to mention the education that you're giving on a daily basis. But I think, the other
You're
aspect,
doing it too.
well, I wanted to mention something because it's not offered to Black women in the same way. And it's really key for other women in the family. And that is genetic testing.
Genetic testing, yes.
Oh my gosh.
Yeah.
Talk about it. Talk about it. Talk about
So
it.
what it is that they've actually looked at studies to see whether Black women would want to get genetic testing. Guess what? Actually, it's more in Black women, but they just don't
Right.
get it offered.
Right.
And so a couple of things that I would say to people who are listening right now, it's very important to know the family history in everything, but especially in cancer. So it's not just your mother, father, brother, sister. It is your cousins, your grandparents, and it's not just, oh, they had cancer, but what type of cancer and how old were they when they had it?
Exactly.
So people tend to say, well, breast cancer. No, guess what? If there's prostate cancer, that can affect the risk for a woman to get breast cancer. There are certain cancers that go along. Once you have breast cancer, the way you get screened for colon cancer changes. It's every 5 years instead of every 10 years. And so and now, I hope we're going back to people being together and family reunions and all that kind of stuff. This is a time to take the pen and paper or your phone or whatever, your choice is, and to get that family tree, because we got to make sure that the younger people don't get cancer.
Right.
There are now ways to prevent cancer if they know that they have a gene for it, for example.
Right. And can act accordingly and protect our children and our sisters. But I'll tell you a story. So my very good friend, his mom just got diagnosed with metastatic colon cancer. And I'm watching health disparities unfold in front of my eyes. This is a family. She worked for the government for her whole life. She has Kaiser insurance. No one ever educated her about getting a supplemental plan for Medicare, right? So she has like the basic Medicare, which is nothing. She felt she has congestive heart failure. So she went to the hospital, was feeling faint. While she was there, they diagnosed her with, well, you have 2 tumors in your colon and maybe one on your liver and maybe one on your ovaries. And she's 89. And so they said, one day they said, we're going to do surgery tomorrow. We'll pick you up. And the next morning they said, we're just going to send you home. You're going to be okay. And sent her. Never told her she was metastatic. Never explained anything about it. They did a CT scan and they did a colonoscopy. Turns out she's never had a colonoscopy in her life.
Goodness.
And so when they told me about this, I was like, well, let me see her chart. Where's the my chart thing, right? So I go in there and I look at her scan, and I'm not a doctor. I'm like, I'm just.
Okay, yeah. Well, you're educated and you're smart and you can look at the information.
But Mets everywhere, Mets in her whole abdomen, Mets everywhere. And so, and they never told her that. So I'm trying to explain to them, you guys, she's metastatic. It is not looking good here. And so we scheduled an appointment. I went with them to the doctor last week with the oncologist. And I said, can you please explain to these people what's going on with their mother? And, both of them are, have master's degrees, are educated people, but your typical Black family was like the Kaiser in the Black neighborhood, right? And so he puts the thing up on the CT scan up on the screen and it's all Black, and so the mother never even looks that way. She looks at her kids to see them freaking out over this horrible scene. And he said, well, so she tried to explain to her what metastatic means, and they're still not getting it. No one knows what that word means. And so I'm like breaking, that means you're going to die. Okay. Like it's really bad. And then he said, well, you can do chemo if you want. Now she's 89.
With
And
heart failure, with heart.
with
failure.
Right,
heart
at that.
failure, right, we'll get you some chemo. And I said, well, have you done a PET scan? Like, are you gonna do a PET scan? Like, are there mets in other parts of her body? Oh, yeah, I guess we could do a PET scan. I'm like, and then they said, but if we'll sign you up for chemo in 2 weeks. I said, well, are you gonna give her a port? Look at her arm, she's 89, she has no veins. Oh, I guess we could give her a port. So we're still in the middle. She actually is having her PET scan tomorrow. But the level of care was so bad.
It's
And the
terrible.
level of knowledge about what they're told her. And I feel like if you don't have an advocate that has any sensibility about being ill or even understanding the science, you're screwed.
Yes,
And
indeed.
and these are educated people. You know what I mean? And
Well,
with
look at, I mean,
this is health insurance, right?
but I want to tell you, this has been studied in the maternal health field. So if you look at Black women's outcomes,
Yeah.
let's say a woman with a graduate degree has a worse
Right.
outcome than a white woman without a high school education.
True, it's true. Irrespective of her level of education, it's still worse.
Isn't that
Unbelievable.
crazy?
So, I mean, but racism runs deep. So this is what I
Yeah.
would say, because obviously I mean, there's always racism, but I think that the the status quo or the mainstream is panicking about all kinds of things. So we're seeing things being rolled back. But this is what I believe. I believe that we have to educate ourselves and we have to reestablish those communities where community leaders in whatever sense, right? Whether you're a leader in your family, whether you're a leader in your church, whatever that is, need to be the ones that are educating and advocating. Because guess what? It's not happening and people are dying.
Not happening. And people are dying every day. I look at my watch every now and then throughout the day and I was like, gosh, somebody just died. Some young woman just died of triple negative. And somebody just got diagnosed. Every day it happens. And so we're really trying to beat the drum on when we trial, So Dr. Gigi, talk
Yeah.
to me. Can you talk to us about, because I heard you tell the story when we were together last about AIDS.
Yes. So when I came to Washington, D.C. back in 1985, the hospital where I worked, GW, where I still work, was 600 beds. It's now 300. I can't tell you how many.
Really?
Yeah, I can't tell you how many people I pronounced dead. And it was a 1-year, 100% death sentence. And you would walk around DC and you could see who had AIDS because they would have the Kaposi sarcoma, which is a type of skin cancer, their hair. There was this disease that would really ravage the brain. And so they would be like demented. And not to mention skinny. It was awful, awful, awful. And at that time, remember, dentists and doctors refused to take care of people with AIDS. People wouldn't touch them. People wouldn't even give them food into their rooms, right? Many people at that time, it was mostly, at least here in Washington at the time, mostly gay men. People were excommunicated. But I just want to tell you, in medical school, I went to University of Michigan in Ann Arbor. The way we were taught about, we didn't even call it HIV then. They called it the 4-H club. Homosexuals, Haitians, drug users or heroin users, and hemophiliacs.
Yeah.
So, of course, Haitians, right, and that's why there's still the stigma of Haitians to this day. And, I remember, and I want to tell you about Fauci and why Fauci is such an important figure to us and the healthcare world. So he was doing, trials. And the people it was mostly gay white community because they're wealthy and they had education.
Right.
And money. So they called him out. They said, you're not working with us in the community. And he said, you know what? You're right. So they was ACT UP. They worked with him to work against the Reagan administration, if you recall, and that whole, you may not recall, but it was a mess. But just to tell you how desperate people were, when they were in the waiting room and they were on clinical trials, they didn't know if they had placebo or active drug. They would mix them up and then say, well, we'll just we'll take half, because at least we'll get active drug.
Get something. Yeah.
And really, based on the knowledge that we have about HIV, all these years of science, which to me, it's a miracle that now it's a chronic disease, just like diabetes or high blood pressure. To me, that's a miracle, because I can't tell you
It's a
how.
chronic disease. It is a miracle. It is a miracle. But even to think about it, but why did they even put a placebo in that trial?
Well, because there was nothing else that worked.
Yeah, I know. So just give them the drug.
Well, because the drug, but remember, the active drug could kill, and did in some cases. So actually, nothing versus
We didn't
something,
know.
nothing,
Right.
yeah, the
Right.
something could accelerate death. And that's why it had to be studied. But it was just a very dark time. But I want to tell you, all that work that all those researchers did in HIV, guess what? When COVID came along, as devastating as it was, we have to remember that a vaccine came up very, very quickly.
Right.
And it came up quickly, not because they rushed in anything. The work was being done. It was being done all over the world. And actually, Trump, when he came in, he cut off funding. There was one person that was working on the vaccine, not the current vaccine type, but the old school vaccine. He would have been ready. So
Wow.
you see how so many things come together. It's the government and setting the priorities of science and which kinds of diseases get funded.
Mhm.
It's the advocacy and it's the science. And so, to us who know anything about Fauci, he, for somebody to say I was wrong and tell me, yes, you're right, I should be working with the community. And if you've heard what he said about COVID, he said, this is yet another example. Why is it that brown and black people are always, paying the price? He's been calling out the disparities.
Let me
You really-
ask you this, because I think you're right. And the Reagan administration really stuck their head in the sand as long as they could, right? For as long as they could deny with plausible deniability. But shifting gears to cancer and looking at the disparities, we have an administration that has a cancer moonshot and that's pumping billions of dollars into, what we hope will be fruitful. How do we make sure that Black and brown communities aren't left behind? And that we're not on the ground while everybody else is headed to the stratosphere and going to the moon?
Well, I think that in this administration, look, we have finally an African-American woman vice president. Diversity counts, because when people are at the table and say, look, multiple myeloma affects more African-Americans than whites. We need to look at the research.
Right.
Prostate cancer, triple negative, all these things. So when you have diversity at every level, at policy, as advocates, as clinicians, as patients, that counts. That makes a difference. So I don't think that, and I just want to be clear, just because you've got melanin in your skin doesn't mean that you're a great advocate. And just because you don't doesn't mean that you aren't fantastic, right? So we know examples on both sides, right? We know of Fauci isn't exactly, has a lot of melanin. He's just been incredible. He's a great example of a caring human being, because he is a human being first and foremost. But I think but diversity can't just be in one thing. It's got to be everything.
Across the board. Yeah, it's got to be across the board. I know we're hoping that, as we get more people involved in 1 week trial, that we can expand it to other disease states. Because really the same kind of education. So far, when we just got new numbers, we've signed up almost 500 women into clinical trial portals.
Beautiful. That's incredible.
That's
four portals on the site. 2 of them are for the Triple Negative Breast Cancer Foundation, 1 for metastatic, 1 for early stage. 1 is breastcancertrials.org, and then 1 is Citizen, where they're matching you to a profile, to a drug profile. So they're a little easier to manipulate than clinicaltrials.gov if you're a breast cancer patient. But we have to keep beating this drum, and now we're hitting the road. I'm on the road. I've been on the road for 2 weeks now. I went to Memphis and went to Chicago. I went to Florida. I'm in Miami again. I'm in Florida for the 2nd time. I'm going to Charleston to a church on Sunday.
Love it.
Mount Moriah Baptist Church. I'm going to
We're
Brooklyn
going to New Orleans.
Wow.
So we're trying to get the road and go where people are. And I was in Memphis, where they have an incredible Black breast cancer community. But one of the women in the audience said to me, you know, everybody's online. We know we're on Facebook and Instagram and TikTok, and we're seeing all the breast cancer stuff. But what about women who don't have Facebook, who don't have YouTube? Or guess what? Whose cell phone is her family computer, where she's got to get her 3 kids to get their homework done, and she only has so many minutes, right? And so I said, you just asked the money question. That is exactly why we are here. And that's where we're really trying to go, where Black women live, work, play, and pray. So I can talk to you, and then you can go home and talk to your sister and your auntie and your grandma and tell them about, you know, clinical trials, and talk about it at your kitchen table, and talk about her story. So we're hoping that it's going to get more people talking, more Black families just talking about health, you know, not waiting until Uncle George gets his leg amputated, or Grandma Pookie passes out from the sugar and has to get something, you know, like, you know, go to the hospital. So we just can't do enough, you know.
And, you know, I have to remind everybody that 1 in 3 people in Washington, D.C., the nation's capital, are functionally illiterate. And
Yeah.
you know, not being able to read is a big shame. People feel very ashamed.
Yeah.
And there's all kinds of behaviors that people try to do to avoid, you know, being outed. Some of them include not going to see the doctor, right?
Very true.
Right.
You know, because they just don't want to be embarrassed. And it's not like we as doctors have a great track record with making people feel comfortable. So I really believe in, you know, faith-based or community-based initiatives, because we're working with a couple of churches now here in DC where the health ministries are highly educated. And peer-to-peer is better. I mean, if I come in from the outside, who am I? But if they have people that are part of their health ministry saying, look, let's do this. I'll go with you to get your, you know, mammogram, or, hey, we're going to bring the mammogram here and you can get it done on such and such a day. That's so much more powerful and effective. And, you know, the clinical trials, let me just say one thing, which is a completely different example. So we have Dr. Chapman here in Washington, D.C. He's just an incredible person who does a lot of work on substance use disorder. So he's got 4 different clinics. He started to notice that the new medicine that they give, that somehow in Black people, they weren't responding as well. So he teamed up with Howard University's pharmacy department, or School of Pharmacy. Turns out that Black people were metabolizing it much faster.
Wow.
Well, guess what? They needed a higher dose.
Right.
But they weren't in the trials. The Black people weren't in the trials.
They need a higher dose. Insurance doesn't pay for a higher dose. And guess what? You will be labeled as, oh, they relapsed, when they actually never got the right treatment in the first place. So that's another place where all of these important aspects come together. Yes, you have to have the medicine. You have to have people that look at gender, ethnic, age differences. You have to have then somebody that's going to advocate with the insurance companies to say, look, our needs are different. And then you're going to have to work with the community to say, don't label people. They actually never got the right treatment.
Wow. You know, that happened to me years ago. My first job out of graduate school was at McNeil with Tylenol, when the 7 people died of Tylenol poison. Remember that case study? You weren't born yet, Mo.
I think just born. Yeah.
Barely born. But I worked on children's Tylenol as a baby brand manager, and we kept getting calls from moms. Well, I gave my kid the Tylenol, but the fever didn't go down. Well, how much did you give? They were underdosing their kids because they were so afraid of overdosing their kids. They were underdosing, and guess what? It didn't have efficacy. It didn't work for them. And so I said, you have to read the package. And guess what? A lot of them couldn't read the package. And so we've now improved a lot of the packaging about that with pictures, right? So fill the thing up to the line and then give it to your baby. And then, oh, wow, it worked. But I think the whole dosing thing, but now I think with Black people, we don't know about dosing because we weren't in the trials.
And
right?
you know, let's call a spade a spade. I think that one of the really important things about partnering with faith-based communities is that that is a place where we've always sort of given it up to God, where we said it's okay not to, not to go to that doctor. God is our doctor. We don't need that therapist. We'll talk to our pastor. Our faith hasn't always mobilized us in ways that
Do the
has
right
been
thing. Yeah.
affirming for our health, right? And we saw some really great examples out of COVID that looked at how faith-based communities came together to educate, to offer vaccines. Like we saw examples of how to do it right. And I think that we really have to study that and look at what we did and repeat that for diabetes, for kidney disease, for hypertension, for
Yeah.
breast cancer, for prostate cancer. Like that's a movement that I think really is ripe, because what used to happen, I used to volunteer with the mobile mammogram van for Fox Chase Cancer Center when I was in grad school and just starting out. We'd go to those churches and they say, I'm not doing that. I'm not getting on there. I don't want to do that. And there wasn't this sort of, leading by example where the minister would say, you know what, I'm going to go first and I'm going to get my vaccine. And then my pastoral staff, we're going to get theirs. And now we want everybody to consider getting yours. And I think that we're going to see more of that. So that's a really powerful tool.
You are right on about that. There were several huge initiatives, Choose Healthy Life being one of them. In DC, there's Temple of Praise and Pennsylvania Baptist Church and All Nations. So we did an event with Temple of Praise where pastors and the bishop that represented 60,000 people, we did a webinar. And to your point, they got vaccinated on the pulpit.
Wow. Isn't that great?
And then they have still 3 times a week vaccines and testing.
Yeah.
And by the way, they fed 3 million meals during this time. So you know what I was saying about the community being the one to sort of take charge of this? This is what I mean. So there's a lot of wonderful work. And the good thing is, yes, God for spiritual healing. And it's not either or, it's this and both of them together.
God. Yeah. And God working through other people like doctors and nurses and whatever to give you the care that you need, pray for, and you got to pray for God's will to be done, but
well, not only that, the faith without works is dead, right? Like you got to do the works part of it.
You got to do the works, and God's working to help you do the works, right? With the people that are taking care of you. So I don't know. It's still, though, we have so many Black families that don't talk about it until somebody's fatally ill or terminally ill, and it's funny because my friends, the family I talked about, they all have different symptoms. The grandson has colon cancer in his 40s. So there's probably something genetic going on.
Did they get tested, this family?
So they're just getting tested now. And it's because I've been like, come on, I'm going to take you to the hospital.
Yes.
But they're all, well, I had blood in my stool last week. Well, what?
Yes.
Or my stomach is distended. I don't feel good. I'm like, what?
Yeah.
So like, how do we get our families just to talk more and do more for themselves? Because we're letting them die.
As I say, not being from the African diaspora and looking at my sisters and brothers who have faced, hundreds and hundreds of years that have impacted the very DNA. And especially now these days, if Black bodies are not valued, and when people go to the doctor and are not believed and are treated so badly, I think a lot of times people just say, well, I'll wait until it gets whatever. So there's so much that has to do also with the psychology of oneself, but also how horribly people get treated, from the person that answers the phone, to the person that checks you in, to the doctor, to the nurse, to all of the system. I mean, there's so many studies time and time again about how Black people get treated for pain, for sickle cell disease, all the things that you just mentioned. So I think that the solution for that has to be a buddy system, where if we care about each other, we ask, hey, how are you doing? What's going on? I know, like when I would go in the summertime, we would go to Egypt. We would have, my grandmother was sort of a healer, but she had an eye to see if there was something wrong with somebody. You don't look right? There's something, your color is off.
That's a grandma thing.
That's right,
definitely
something is
a grandma
going
thing.
on. But
Yeah.
think about it, with the fragmenting of those community, we need to get that sort of back, because you know, it's sometimes you just
Right.
pass by and says, are you okay? You look
Right.
different.
Right. But and that's one thing that's I treasure about the breasty community. It's a club that you don't want to be in, but
Right.
once we all have this unconditional love. And so now I'm saying, pass that love on to your family, get them checked, get genetic testing, take care of yourself, make sure you're checking your breast, tell everybody in your family to check your breast and talk about it, because it's got to go beyond just our little world of women who've had breast cancer. And it's got to go on to women who have heart disease and high blood pressure and kidney disease, because we have all these diseases and we have to really take care of each other, because no one's going to do it for us.
No, no. You know who I have to introduce you to, and you should really, she's wonderful. She's a friend, Rhea Blakey. She is at the FDA, and there is a program that just started a couple of years ago called the Black Family Cancer Awareness Reunion.
Cool.
And I think they've got an upcoming event on Juneteenth.
They do. Yeah, they do. And we're actually going to do two of those events for Black Family Cancer Awareness Week or whatever. We're going to do a show with Komen about it, and then we're going to do a show, another show with somebody else. I can't remember. We're doing a couple of events with that. It's in a couple of weeks, so that's a good thing. But I'd love to meet her. Just to love to meet her. And
let me tell you, there are so many incredible Black women just doing their thing and advocating. I mean, that's one thing that I love about doing this kind of work, because you see so many incredible human beings that really love each other.
Yeah,
Love
each
right?
other. Love, true love. Tell us about the Rodham Institute. Like, what are you doing?
Sure. So, the reason I started it 10 years ago was because here I am in DC, the capital of arguably the richest country in the world. And there is a 26.5-year gap in life expectancy here. If you live in the richest part, on average, you live 94 years. And in the poorest part, 66.5 years. And in the poorest part, the HIV rate is the same as Namibia. The infant mortality rate is the same as El Salvador and Cambodia. And we know that what impacts health more than healthcare, healthcare only contributes about 20% to life expectancy. It's the water you drink, the air that you breathe, where you live, your education, the food that you eat, the structural social determinants of health. And I felt that especially academic, medical, medicine, that we always hold ourselves aloof, kind of look down on people from the community. And it's like, all of us train on the backs of poor people, poor Black people mostly. And this is what you're going to do and turn around and treat people like, no, this ship had to be right size. We have to bend over backwards to make up for just the inequities and the historical years and years, if not centuries, depending on how old the university is.
Right.
So please visit our website, but we focus on community collaborations, 160 partners. We've done webinars. We distributed 560,000 masks and hand sanitizers. We've got another area of priority, which is educating people in the healthcare workforce around health equity. And the third one is workforce, because guess what? Only 42% of kids in Ward 8 graduate from high school. And if all I did was to get them to graduate from high school, that would add 10 years of life to their life expectancy. So we got to get them.
Say that again.
In Washington, DC, we have 8 wards. The poorest ward, Ward 8, which is almost exclusively African-American, only 42% of kids graduate from high school. If all I did as a doctor was to get those kids to graduate, I would add 10 years to their life expectancy. That's more than anything that I could give a prescription to.
Incredible.
Wow. And that Ward 8, we have the highest mortality rate of breast cancer for Black women in the whole country.
I know. Well, Washington, DC is #1 per capita in cancer deaths.
Sure is. I
So
did my
it's-
fellowship at Hospital Center, and really, and the differences even across town between Hospital Center and Georgetown main campus, the difference in literacy, in mortality, in treatment options and diagnosis, in what patients were offered and what they understood just across the same health system was really staggering. And the amount of time it took to really get that patient, talk to your family, bring that family member in. What do you need outside of just treatment that's going to enable you to even stay in treatment, right? The resources just were so limited.
Right.
You know what I've found? That leading with love and kindness is the biggest
Yeah.
healer. When a person feels like, they've got this diagnosis and they're not alone, and that you're going to do your best, even if you can't do everything, but that I care about you, that you are somebody that you're worthy, you're just as important, you're a VIP just like every other VIP, and that love and kindness really has an incredible impact. And you're right, there are all these other things, but one of the things about DC that people don't realize, at least in Washington, is that there are actually a lot of resources, but people just don't know
They don't
about
know about them. They don't know
so
about them.
one of the things that I want people
It's
to
so true.
download, if you download Aunt Bertha, it's an app that's available all over the country. You
I'm gonna
put
put
in
it on
your,
here.
yeah,
Aunt
Aunt Bertha. And if you put in like you need food or transportation or healthcare or anything, it'll come up. There's also a phone number that you can call in, and it's the same all over the country, 311. Just like there's information, used to be 411 and then 911, 311 connects you with resources.
Great, that's great.
Fantastic.
That's fantastic to know. Oh my gosh, we have so much work to do. We have so much work to do. And we really just have to keep beating this drum about education and taking care of yourself and knowing her story and talking to our families. Because, what do you say, Mo? The secrets that we keep from each other are killing us.
They really are. And,
Well-
and I see patients every day who still don't want to tell their family members. They want to go through this alone. They think that it's better to suffer in silence and to be a burden, right? That stigma of being a burden to your family is it's really crushing.
I think it comes back to, this is what I try to tell people about allowing people to take care of you.
Yeah.
Yeah.
Kind of switch the parent. My grandmother used to call cancer the word that shall not be mentioned.
Mm.
Right. Oh, yeah. Oh, yeah.
Mhm,
For sure.
mhm.
For sure. But you know what? You brought up it, lead with love. And, to me, health equity doesn't exist. It's health inequity. We're not going to get to health equity until we all practice the golden rule. And I learned this from treat other people as you want to be treated. So every doctor, every healthcare professional needs to treat their patients like they would expect to be treated, like they would treat their mother.
Do their best.
Right.
Do their
And
best.
until we get that kind of care, it's going to be, we're going to have, and I hate the word underserved. I hate that word. Because what does that mean? That means you have a dinner party, you invite 10 people, but you only make enough chicken for 4 of them. And that just assumes that the other people at the table have a place setting and a fork and a knife, but they just haven't eaten chicken. And really what's happening is we're the unsupported because we don't even know there is a party. There's no invitation to the party because we're unsupported. So I don't want to hear that. I hate when people say that word because it's really bigger than that. We're unsupported.
The word I use is under-resourced.
Under-resourced. There you go.
There it is.
Unsupported. Yep.
Yeah.
Because we don't have the support or the resources that we need to do this, to take care of ourselves.
Dr. Gigi,
And we
let
have to fight for ourselves.
me ask you this. What comes next for you? What are you excited about
Yeah,
with your
yeah.
work and what should people expect and how can they support you in your movements and in your work?
Wow, thank you. Nobody's asked me that before.
Yeah, what's
So,
exciting you? Yep.
First of all, I love to share and to learn from others about how we can do this best. So I would ask people to please sign up for our newsletter. We've got a lot of webinars that we do, and we try to really embrace everybody. There are many people who are left out. There are what I call minorities within minorities, right? Like disabled people.
Yes.
Elderly or
Yes.
LGBTQ or whatever. So
Right.
we really try to, throw the net very, very wide because really, eventually, white, black, or whatever, we all are going to be in a group where there is going to be discrimination, because if we live long enough, the
Right.
elderly are discriminated.
Right. Oh, my gosh. Yeah.
So what I'm doing right now, working with CDC Africa, because they've got a problem in terms of vaccination acceptance. So we want to share the lessons we learned with the Black Coalition Against COVID. Also within Africa, I'm very happy to tell you there's a movement where African countries are working together. And one of the things that I've always felt that I could do was to help build a bridge between Africa and the African diaspora. And what they're very interested in doing is this group called Afro Champions, is bringing the talent from the African diaspora to help in whatever it is, whether it's in business or health or education. So how would I like to be supported? I would like to, of course, funding for the Rodham Institute, but the other thing that I would say is that, I think we were talking about this a little bit earlier, to unmask the hypocrisy that's in academic medicine. It's a dirty little secret that exists.
We got to chat about this some more. You're right.
Yes, but I think that, and I'm talking also about the people who work there. So the person that I work right alongside with, that puts patients in the room, we work together. We have homeless women working. We have women that have to work at McDonald's.
Yeah.
I mean, so it's like, you hear about white coats for Black lives or diversity, equity, and inclusion. And it's the biggest amount of hypocrisy that I see. So working towards, uncovering that and not letting people get away with sloganeering, I guess. I hope I answered your question.
Oh, very much so.
That's
Because I think it brings up so many great things to have our next discussion, because you certainly will be back, and we got to talk more about those folks who are on the fringes. Like we keep saying, we're going to do another show, and we're going to focus not just on Christian faith-based communities, but those who are not
faith.
right,
Yeah.
not Christian.
Well, I'm Muslim. I'm Muslim.
What happens under the burqa? What happens under the
Yeah.
sari? What happens in the
Right.
mosque? What happens in these
Right.
conversations and places where we don't go? I have a patient who's Asian Indian. She's Vietnamese, and I went to the Hindu temple, and I gave a talk on breast health, and they said a physician had never ever come out before to talk to them about anything.
Wow.
And there's opportunities for us to collaborate in these spaces as well. So
Yeah.
you're bringing up some great points, and I hope that through putting your site and your mission on the chat, we're going to get some support for you,
Thank you.
as well.
Thank you
Yeah.
so much. Thank you, ladies.
And you got to come back and hang out with us.
Thank you. I would love to. Thank you so much for inviting me. This has been inspiring for me. You've given me a lot of good energy, and I appreciate you. Thank you.
Absolutely.
So
Listen,
grateful for you. And I'm going to call you. We're going to have a date. Okay.
Oh yeah.
All righty.
Love
Be
to
well.
chat more.
Take care.
Take
Bye-bye.
care.
Breasty love. Breasty
Bye-bye.
love.
Oh, we got to do it. You know it. There's that
Yeah.
breasty love. Thank you to Black
See you next
Doctor,
week, guys. We're going to have a great show
our
next week.
sponsors.
Bye-bye.
Thank you for our sponsors. I actually have to call them out because we're doing this for our clinical trials work.
Right.
And we had some great sponsors to help us do when we trial. And we really are so grateful for everything they've done for us. Genentech, Bristol Myers Squibb, AstraZeneca, Novartis, Daiichi Sankyo, Seagen, and Pfizer. So thank you guys. Thank you for reminding me of that, Mo, because we've been so blessed to be able to do this work, and they help us every day.
We
And I was just with
appreciate it.
most of them at ASCO, so we appreciate you.
Great.
Thank you.
Okay.
God bless
Bye-bye.
you.
Bye-bye. Bye-bye.